Hello, dear students. We are still together in the topic of inflammation. This is lecture number 3. Before that, in the previous lectures, we have covered the definition of inflammation, types of inflammation, and then we started to learn more about acute inflammation, the definition, the causes, the reaction or the response in the form of vascular changes, cellular events, and also we have learned more about the inflammatory exudate. By the end of this lecture, we should be able to list the important chemical mediators of inflammation, their sources, and to highlight also their functions, to list the local signs of acute inflammation, and to describe the pathological features of the types of acute nonseparative inflammation, such as the serous, fibrinous, allergic, catarrhal, pseudo membranous, hemorrhagic, and necrotizing inflammation. In this lecture, together, we are going to explore the chemical mediators of inflammation, and also we will start to understand more details about the types of acute inflammation. So, chemical mediators of inflammation. Over the previous 2 lectures, we have mentioned many chemical mediators or substances that are controlling or regulating or affecting the inflammatory response in one way or another. So now it's time for us to start to understand more about those chemical mediators. Where do they come from? What do they do? And what are the most popular or most common chemical mediators that are involved in the acute inflammatory response? The chemical mediators of inflammation usually come from 2 main sources. We have the cell-derived mediators and the plasma protein-derived mediators. The cell-derived mediators are either one of 2. Either they are already normally present in intracellular granules, and when the cells are activated, those cells with the granules, they will rapidly secrete the pre-formed mediators in their cytoplasmic granules. And the best example for that is the histamine that is present inside the mast cells. The other option for the cell-derived mediators is to be synthesized de novo, or like in this new situation of inflammation in response to a stimulus. So they were not stored anywhere before, they were not formed before, but they are synthesized newly in response to some injurious agents. And the best example for that is the prostaglandins. For the plasma protein-derived mediators, we have 3 main factors. We have the complement component proteins, we have the kinins, and the coagulation system proteins or factors. These actually will undergo cleavage by some proteolytic factors or enzymes to start to be active. So they are already present in inactive forms, and after proteolytic cleavage, they will be transformed into active products that will undergo some important functions in the acute inflammatory response. So together we will list some of the most common mediators. So from the cell-derived mediators, the most common are the vasoactive amines like the histamine, serotonin, and neuropeptides like substance P. We have also the arachidonic acid metabolites like prostaglandins and leukotrienes. We also can see in acute inflammation lysosomal components, and these come from the macrophages and the neutrophils. We have also a role of a platelet activating factor, and we have functions of the cytokines in acute inflammation. So cytokines such as interleukin-1, tumor necrosis factor alpha, tumor necrosis factor beta, and interferon gamma are going to have a lot of roles in acute inflammation. Last but not least, in the cell-derived mediators are the free radicals such as the reactive oxygen species or reactive nitrogen species or the nitric oxide. The plasma-derived mediators, we have the kinase system, like the bradykinin. We have the clotting system and fibrinolytic system, such as the fibrin and its products. And we have also the components from the complement system that we already mentioned before, like C3A, C3B, and C5A. Together, we can revise in our minds what are the functions of those complement system components. Then now we come to the most important question. What are the functions of those different chemical mediators? Or we can ask ourselves the question in an opposite way. In each step of acute inflammatory response, what are the involved chemical mediators? So we have key steps in the acute inflammatory response, like vasodilatation and increased vascular permeability. We have also the leukocyte recruitment and activation. Acute inflammation is associated with fever and pain, and also it will show tissue damage. So each one of those steps or functions are associated with certain chemical mediators. So let's start with vasodilatation. Vasodilatation is always controlled by histamine and prostaglandins. Histamine comes from the granules of the mast cell. Prostaglandins are from the arachidonic acid metabolites. Then we have the increased vascular permeability, which is the next step in the vascular changes of acute inflammation. We have also a very important role of histamine. But not only that, we have also action of C3A and C5A as complement components. We have some leukotrienes, and we have the action of bradykinin. For the leukocyte recruitment and activation, the most important are the tumor necrosis factor, interleukin-1, C3A and C5A, chemokines of different types, and also the leukotriene B4. For fever to develop in acute inflammation, the main mediators are tumor necrosis factor, interleukin-1, and prostaglandins again. Pain is mediated by prostaglandins and bradykinin. And finally, tissue damage will mostly happen in acute inflammation because of the lysosomal enzymes that come from the leukocytes, the reactive oxygen species, and also the nitric oxide. So we will see here that some mediators are repeated. So for example, prostaglandins are responsible about vasodilatation, fever, and development of pain in acute inflammation. We can see also that histamine is mainly related to the vascular phenomena, like the vasodilatation and increased vascular permeability. We can see that tumor necrosis factor and interleukin-1 share many functions, like the leukocyte recruitment, activation, and also development of fever, and so on. So we need to put these information in our mind so that when we are asked in any question like MCQ or even in essay questions about the roles of different mediators, we will be organized and we will have a map of these mediators and their functions in our mind. And there is no better map than this nice table. So we need to take some time and look at this table repeatedly so that we can keep it and memorize it in our mind. All of this will take us to the next station in our topic. What are the signs of acute inflammation? So the word signs means the features or the changes that we will see in the patient when we examine him or her in cases of acute inflammatory lesions. So suppose there is a patient who has an acute inflammatory focus in his arm. What are the signs or the changes that we are going to see around this inflamed area or over this inflamed area? First of all, the area of inflammation will be painful. So if the inflammation is in the arm, we will have pain in the arm, or in the leg, we will have pain in the leg, etc. So pain is one of the signs of acute inflammation. The next sign is heat or hotness. If we touch the area of inflammation, we will find it has increased heat. It's more hot if we compare it to the neighboring normal area. Then we have redness. We will see more red color in the area of inflammation if we compare it to the neighboring normal areas. The sign number 4 is swelling. Usually in acute inflammatory foci or lesions, the area of inflammation will be swollen or increased in size. And last sign of inflammation is loss of function. So the area that is inflamed will not function well if we compare it to the healthy organs. So let's try to understand the reasons beyond all of these signs. First of all, the redness and the heat or the hotness. Why the area of inflammation will be red and hot? This is caused by the vasodilatation and increased blood flow to the area of inflammation. So these two vascular changes are responsible about the redness and hotness of the inflamed area. The next one of the signs is the swelling. Why we have swelling? Because as we previously illustrated, there is formation of inflammatory exudate. We have outpouring of fluid from the blood vessels to the interstitial tissues. So the tissues will be having exudates and edema. This is why the area of inflammation will be swollen. Then why we have pain? Pain is caused by two main reasons. First of all, there are mediators that are released in the area of acute inflammation that lead to painful sensation, like prostaglandins and bradykinin. The next cause of pain is when we have inflammatory exudates in the interstitial tissues, the tissues will be kind of stretched and irritated. So this will be like very alarming or irritating to the nerve endings. So nerve endings are not going to like this inflammatory exudate and all of this hassle that's happening in the interstitial tissue. So they will start to send signals that are going to be translated as pain. The last sign of inflammation is loss of function. Why we cannot, for example, move an inflamed arm or inflamed finger? Because actually of the previous two signs, because this inflamed finger or arm is swollen, is painful, so it's not easy to function or to use this finger or this arm. So actually loss of function is because of the pain and the swelling together. So these are the main 5 signs of inflammation, and this is their explanation. So we have, again, let's repeat, we have redness, hotness or heat, swelling, pain, and loss of function. Before I leave this slide, I want to highlight one thing about pain. Actually, pain is a symptom, something that the patient will say, like, I'm going to go to the doctor and say, I have pain in my arm. But when the doctor touches my arm and I feel the pain, this is called tenderness. So actually, pain is a symptom that the patient will describe, and tenderness is the sign that the doctor will see or will translate when he examines a patient and the site of inflammation is painful for the patient. So this is called tenderness. Before I move on, I want to highlight some concepts. When we say morphology or pathological features or pathological findings, usually we mean two things: the gross description of the organ that is diseased and also the microscopic description. Gross description means what we see when we examine an organ itself or a tissue. So this is a doctor here who is cutting certain organ, and he is going to see changes, report these changes, and also he will feel these changes. So it's seeing things and feeling things. This is the gross examination. And then we have microscopic examination, when the doctor starts to cut pieces of the organ, and then these pieces will be processed and put on a slide and examined by microscope. We will see the changes microscopically in those tissues. So actually, they are not separate things, they are continuous. So let's say, for example, if grossly I see an area that looks dark or brownish, I will translate that this area grossly is dark and brown, so most probably under the microscope this area will show hemorrhage or dilated vessels, and so on. So they are actually continuous. They are like two sides of a coin. The next topic for this lecture is the morphological patterns of acute inflammation. To understand more about morphology of acute inflammation, we have this very nice illustration. This is a normal tissue of the lung. The lung is formed of alveoli, and these are actually spaces that are having walls in between them, as we can see here. These walls are called the alveolar septa. So we have spaces, empty spaces, these white spaces, and we have septa or fibrous tissue walls in between them. And these walls are lined by some cells and have some vascularity, as we can see here in the normal cases. If there is acute inflammation, we have two main events, as we described before. We have vascular changes and we have cellular events. How this is translated on the microscopic section or on a slide. The vascular changes will be seen as vascular dilatation and congestion. So if we look here at this section and compare it to the normal, it's very clear here that there is a dilated vessel or congested vessel that is filled with blood. And even here, the small vessels in the alveolar septa are congested and they look more red than normal. So this is actually a representation of the vascular phenomena. The next step in acute inflammatory response, as we described, is the leukocyte recruitment and activation. So as we can see here in this slide, or this image from a slide, associated with the vascular phenomena, we start to see cells that are coming to the area of inflammation. These cells are leukocytes, and this is a beautiful example of recruitment. They are called to the area. So compared to this section that was totally empty, the alveoli actually here were totally empty. Here we have infiltration by inflammatory cells or leukocytes, denoting the cellular changes or cellular events of acute inflammation. Another thing we want to point out here is a terminology rule in pathology. Any inflammation in an organ, we will add to the name of the organ the suffix itis. So, for example, inflammation of the tonsil is called tonsillitis. Inflammation of the appendix is called appendicitis. Inflammation of the colon is called colitis. Inflammation of the pharynx is called pharyngitis. Sometimes we add the name of the organ but in Latin. So, for example, stomach inflammation is called gastritis. So gastro is the Latin term for stomach. The same for the liver. The liver inflammation is called hepatitis. Hepato is again a Latin term for the liver. Sometimes we have exceptions, things that are completely different than the name of the organ. Most common, let's say, in the lung. Inflammation of the lung is not called lungitis. Inflammation of the lung is called pneumonia. This is the inflammation of the lung. So this is a big exception for the rule. But overall, we can apply this rule to many organs. So now we are ready to know the types of acute inflammation. Let's stop here and remember that inflammation in general was divided into acute and chronic types, and we have listed some differences between both of them. Now we are ready to know that acute inflammation is also divided into different types. Those two types are called acute non-separative and acute separative inflammation. So to know what are those types, we need to understand what is the meaning of separative. Then we can explore the different types. So what is the meaning of the word separative? Separative inflammation means that this inflammation is associated with formation of a material called pus. The word pus means certain fluid that is yellow, creamy, and it has certain composition. This fluid will be formed in the presence of certain types of bacteria, not with all types of inflammatory responses. So, if any inflammation is associated with pus formation, this inflammation will be called separative. If the inflammation is not containing pus, it will be called non-separative. So this is an example of a separative inflammation. It has this yellow creamy fluid, which will be comprised of certain components we will explain later. I'm sure many of you have seen something like this, maybe not that big, but at least some of our acne sometimes develop into small lesions that ooze some yellow creamy material. This is pus. This is a type of separative inflammation. So back to our scheme, acute inflammation is divided into non-separative inflammation, or in other term or other word, the inflammation that will not show pus formation. And we have separative inflammation that will show pus formation. The acute non-separative inflammation has many forms. Each one of those types has certain characteristic features and happen in unique situations. So together we will explain the different types of acute non-separative inflammation. We will start with an inflammation called serous inflammation. This is an example of serous inflammation. Again, many of you have seen that. This is herpes virus. Sometimes we have these vesicles around the corners of our lips or even the undersurface of the lips, like here or over the upper lip. This is herpes virus infection. These vesicles sometimes are filled with fluid that will rupture at some point. Also, this is another example of serous inflammation. This is a patient that has severe burn. And again, we can see that if we are burned with hot fluid or water, we can see some kind of vesicles or blebs or bubbles on the surface of our skin that is filled with fluid. This is a second-degree burn. Serous inflammation. Serous inflammation is characterized by forming watery, protein-poor fluid, relatively protein-poor, because in acute inflammation we have said before that the exudate is protein-rich, but in this type of inflammation the proteins are not so many. It's not too much content of protein. It's relatively protein-poor if we compare it to the other types of acute inflammation, and it's kind of watery inflammation. So usually this will happen, as we just mentioned, with burns and skin blister. The blister means the lesion that we just have seen, like a bubble over the surface of the skin that is filled with fluid. Or also it is common to happen with viral infections like herpes simplex that we saw in the previous photo, and also with some effusions in the sacs. So let me say that this serous inflammation is common in the serous sacs, or the serous membranes that are covering our internal organs. The most common serous membranes are the pleura that is covering the lung, the peritoneum that is lining and covering the organs in the abdominal cavity, and the pericardium that is covering the heart. And those different serous membranes, when they are inflamed, most probably because of viral infection, we will see accumulation of fluid in those cavities or those membranes, and this accumulation of fluid is called effusion, and this is a type of serous inflammation. Here also in this microscopic photo we see skin, epithelium, and dermis, and here we can see a space. This space was containing fluid that was processed, and instead of the fluid now we see an empty space. This is an example of a vesicle or a blister, and most probably this is a serous type of inflammation. So to summarize, serous inflammation, the most characteristic feature is containing watery, relatively protein-poor fluid. The most common causes is the burn and the viral infections that can affect the skin or the serous sacs, such as pericardial effusion and also other types of effusion in different serous sacs like the pleura or peritoneum. The next type of acute nonseparative inflammation is called the fibrinous inflammation. So the fibrinous type of acute inflammation is called the fibrinous because from its name it has increased amount of fibrin, and we mentioned fibrin before in the components of the inflammatory exudate. It's coming from its precursor, the fibrinogen, and it has important functions such as localizing the infection and forming a support system or a scaffold for the leukocytes to migrate inside the interstitial tissue in the chemotaxis process. So as we can see here, we have a very good example of fibrinous inflammation in the inflammation of the serous membranes, especially the pericardium. The pericardium is composed of two thin translucent layers around the heart. The visceral pericardium attached completely to the heart and a kind of potential space, and then the parietal pericardium, another very thin translucent layer. If we have a fibrinous inflammation in the pericardium, the fibrin will accumulate between those two layers. And if we look at the heart from outside, we will see accumulation of this grayish white fibrin. If we try to separate the two layers from each other, like what's happening here, separating the layer, this is the parietal layer and this is the visceral layer on the heart, we will see the fibrin threads connecting between both of the layers in a very unique appearance. So this is a fibrinous form of inflammation. So usually the fibrinous inflammation happens with more severe injuries if we compare to the serous type of inflammation. So the severe injuries will result in more vascular permeability and more leakage of components like fibrinogen that will be converted to fibrin and will be precipitated in the inflamed tissues. The most common types of fibrinous inflammation occur in the inflammation of the body cavity lining, like the serous membranes we mentioned before, pericardium, peritoneum, and the pleura. So inflammations like pericarditis, peritonitis, and the pleuritis are usually fibrinous in nature, or maybe serous also, like we already mentioned before. We can also see fibrinous inflammation inside the lung alveoli in cases of the inflammation of the lung, which is called pneumonia. So let's try to explore the gross and microscopic features of one of the examples of fibrinous inflammation, which is fibrinous pericarditis. So here we have a closed heart and we have the pericardium over the heart. If we open the pericardium, it has two layers. It has visceral layer on the heart itself, and we have a parietal layer. We will see both layers being opaque and rough and grayish white because of the fibrin, and we will see the fibrin threads here interconnecting between both of the layers together in a unique appearance grossly that can mimic bread and butter. I know this may sound gross, but it's really mimicking bread and butter. If we have two pieces of toast and the butter in between and they are stuck together, and then we try to separate those two pieces of toast, we will see this appearance of something looking like the fibrin threads that are grayish white in color. So this is bread and butter appearance, one of the unique appearances or gross descriptions in pathology. Under the microscope, if we examine this type of inflammation, we will see the fibrin in the form of eosinophilic or pinkish meshwork of threads, or sometimes as coagulum, which means like a homogeneous material, like a mass of pink material in the tissue, and it will be also entangling or containing some of the inflammatory cells. So this is the key feature of the fibrinous inflammation, the presence of fibrin grossly and microscopically also. What will happen next after fibrinous inflammation will occur? We have actually one of two options. Either the exudates of the fibrinous inflammation will be degraded by fibrinolysins, and then the debris or the material that is present will be removed by the macrophages. This will lead to a very nice fate that is called resolution. Resolution means that all the inflammatory exudates fade away, go away, and the tissue restores its normal structure. But also with fibrinous inflammation, sometimes the fate is not that good. Sometimes there is a lot of fibrin, and this also is initiating fibroblast activity and the new blood vessel formation, a process of healing that is called organization. This process we will understand more and more about it in another chapter called healing and repair. So presence of fibroblasts will lay down collagen and will lead to something we call it scar formation, a lot of collagen. Actually, this is not a very good fate, because if we lose parts of the tissues in any organ and we replace it by fibrosis or collagen or scar, this means that we are losing the function of this part of the tissue. If we had cells here in this part of the tissue, the cells are gone now. So this is actually a type of repair or healing in the cases of severe forms of inflammation, and it's not a very good fate. The next type of acute non-separative inflammation, we have a catarrhal inflammation. Please remember with me that in all the previous types of inflammation till now, we didn't say a word about pus, because we are in the section of non-separative inflammation. So what is catarrhal inflammation? Catarrhal inflammation is a very mild type of inflammation of the mucous membranes, such as the mucous membranes of the nose and the mouth. It's a very common thing that we also in cases of common cold. In cases of common cold, we have a lot of mucus secretion, and this is the hallmark of catarrhal inflammation, because the mucus secreting epithelium is, when it is irritated, it secretes a lot of mucus. This is why it is giving this appearance or this feature. So if we examine the tissues grossly, we will see the mucous membranes being red, hot, swollen. All of these are features of acute inflammation. And then later on, we will see excess mucoid discharge or secretion. And with time, it becomes more thick, and sometimes it becomes yellowish. And I'm sure, again, we are all familiar with that in cases of common cold that we have all seen. If we examine that under the microscope, we will see that the mucous epithelial cells are swollen because of accumulation of mucus in their cytoplasm. And also the tissues underneath the epithelium are going to show increased blood flow, which we call it also hyperemia. We can see also edema, which means extravasation of fluid in the interstitial tissue. and we will see neutrophilic infiltrate. That is a hallmark of acute inflammation. So all of these are the main features of the catarrhal inflammation or the inflammation of the mucous membrane. The best example is common cold. The next type of non-separative inflammation is called pseudo membranous inflammation. Let's start first with the name, pseudo membrane. Pseudo means false, not true. And membrane, we all know what's the meaning of membrane. So in this type of inflammation, we assume from its name that we have a structure that looks like a membrane, but it's not a true membrane. It's not a real membrane in the body. It's something that is formed artificially in the course of this type of inflammation. So this is actually one of the very severe inflammatory responses of the mucous membranes. It happens commonly with two main organisms: diphtheria organism, infections of the oral and upper respiratory tract, and another organism called Shigella that affects the large intestine in a disease called the bacillary dysentery. It's called the bacillary because of the Shigella bacilli. This is the causative agent. So in those two diseases, we see the pseudomembrane formation. So why we have this pseudomembrane? What happens here? These organisms are characterized by one common feature. They secrete very powerful toxin. This toxin is like a poison to the epithelium. Once the toxin is secreted, the epithelium gets dead and necrosis will happen. So this necrosis is very irritating and will elicit acute inflammatory response. So with the necrosis, we will have also the inflammatory exudate. And exudate means a fluid rich in fibrin and cells. And all of this is going to mix with the necrosis, with the bacilli. So this whole cocktail is going to form a layer over the epithelium called the pseudomembrane. And we can see here a good example of diphtheria of the oral cavity here and the pharynx, oropharynx. We can see something dirty yellowish over the wall of the oropharynx. This is the pseudomembrane. Actually, it can be detached from the underlying surface. So this pseudomembrane again is formed of the organism, the necrotic material, the fibrin, the neutrophils, and also some RBCs that are extravasated from the blood vessel. The membrane is grayish-white dirty and is loosely attached to the underlying tissue, and it can be detached or it can be removed, and it may leave some bleeding ulcers underneath. We are only left with one last fact about this type of inflammation. This very powerful exotoxin can leak to the circulation and lead to severe condition called acute toxemia that we will mention inshallah in the last lecture of acute inflammation. So this is all about the pseudomembranous inflammation. We need to remember that it's severe form. It is common with diphtheria and bacillary dysentery caused by Shigella. It is caused by presence of severe, powerful exotoxin that leads to necrosis of the mucosa with the exudates of the inflammation. The next type of the non-separative acute inflammation is called the allergic inflammation. And I think all of us are familiar with the term allergy. So what is allergic inflammation? It is an inflammation that happens because an antigen-antibody reaction. And mostly this antigen is exogenous. Sometimes also it is endogenous. A common causes or diseases of allergy, we have the eczema, urticaria, and allergic rhinitis. What is rhinitis? It is inflammation of the nose. So inflammation of the nose is not nositis, it is rhinitis, because this is the Latin term for the nose. And also the bronchial asthma, very common allergic disease. With all of these conditions, we will have allergic inflammation that is characterized by excess amount of exudates and fluids leading to edema. This is number one. Number two, we have here a very unique guest in cases of allergy. We have the eosinophils. And this is the first time we mention eosinophils in inflammation. Mostly in acute inflammation, we mention the cell that predominates is the neutrophil. But here in the allergy, because of the nature of the disease, there is recruitment of eosinophils in the tissues and also in the blood. So this is very important point to remember. The last types of nonseparative inflammation are the hemorrhagic and the necrotizing types of inflammation. What is a hemorrhagic inflammation? It's again a severe form of inflammation that is characterized by extensive vessels damage, and when the vessels are damaged, we have extensive areas of hemorrhage also. And one of the examples is called acute hemorrhagic pneumonia. And we said before that pneumonia is inflammation of the lung. By the way, the P here is silent. It is not pneumonia, it is pneumonia. So this is one of the severe forms of inflammation. And we can see here grossly very characteristic appearance of dark brown tissues denoting underlying extensive hemorrhages. The next type of inflammation, this is not very common, is necrotizing inflammation. And with the name necrotizing, it means we have extensive necrosis in this type of inflammation. And a common condition here for this type of inflammation is called Vincent Angina. What is Vincent Angina? It is one of the conditions that lead to painful ulcers or painful inflammation in the mouth and the throat that is caused by certain organisms. And it is characterized by increased tissue necrosis. So both of those types are the last types that we are going to mention in the acute non-separative inflammation, the hemorrhagic and the necrotizing. So now, after we completed the types of acute non-separative inflammation, we are ready for some activities. In this activity, we have different types of acute non-separative inflammation, and we have their characteristic features. And we need to try to connect each type with their characteristic features. So you can pause the video now and try to read all of the features, then resume the video to find out the answers. So let's start with the fibrinous inflammation. Which one of those features can be characteristic of fibrinous inflammation? Yes, it is when the fibrin is precipitated on the inner surface of the serous membranes and leads to opaque, rough appearance, giving bread and butter appearance in those organs. The next type, the allergic inflammation. What is the best description for allergic inflammation? Yes, it is characterized by outpouring of excess amount of exudates or fluids causing edema with increased eosinophils, and this is common in cases of rhinitis, inflammation of the nose, and in cases of urticaria, which is an allergy of the skin. Next, we have pseudomembranous inflammation. What is characteristic of pseudomembranous inflammation? Yes, usually it happens with infection that's or a microorganism that secretes exotoxin, leading to necrosis and the formation of exudates that are rich with fibrin. Along with the necrotic material, it will lead to formation of pseudo membrane that is dirty, whitish, and loosely attached to underlying tissue. Most commonly, this happens with diphtheria or a disease called bacillary dysentery. Next, we have catarrhal inflammation. What is unique for catarrhal inflammation? Yes, it's happening when the mucous membranes appear red, hot, and swollen. Then we have excess watery mucoid discharge because of irritation to the mucous epithelial cells, and it is common in common cold. Last, we have the serous inflammation. Which one of the remaining can be a good description for serous inflammation? Yes, we have outpouring of watery, relatively protein-poor fluid, and most commonly it happens in cases of burn and viral infections. Then we are left with one option that we don't have a type of inflammation for, but if we read it, we can recognize its type. It's a severe form of acute inflammation characterized by vascular damage and hemorrhage, like acute hemorrhagic pneumonia. So what will be here the type of inflammation? It will be hemorrhagic type of inflammation. The next activity here is a morphology test, an appearance test. From the appearance of inflammation here, you can decide its type. So here we have an open mouth. In the oropharynx behind, we can see a structure that is covering the surface. It is dirty grayish white. What would be the type of inflammation here? Pseudo membranous inflammation. Is it a separative or non-separative? Non-separative. What is the meaning of separative? Pus. This inflammation has no pus. What is pus? Please wait with me or bear with me to the next lecture. Then we have this image. What is the type of inflammation here? In this heart, hemorrhagic type of inflammation. Then this image is showing also a closed heart with an opened pericardium around it, and we have these threads here. So what would be the type of inflammation? Fibrinous inflammation. What is the gross description? Bread and butter appearance. So with that, I'd like to thank you very much for listening and bearing with me. And we will move from this lecture to the next one, in which we are going to discuss the other type of acute inflammation, which is the separative inflammation. Thank you again.